Every sodium, potassium, chloride, and calcium result your blood gas analyzer reports comes from the same underlying physics. A thin membrane generating an electrical voltage proportional to how many of that specific ion are floating around it. Not a color reaction. Not light absorption. A voltage, measured directly off a membrane no thicker than a few hundred microns. Precisely. An ion-selective electrode, or ISE, uses a membrane that develops an electrical potential specifically dependent on the activity of one target ion in the sample, following predictable electrochemical laws. The technology's clinical lineage runs through glass pH electrodes developed in the early 20th century, through potassium-selective valinomycin membranes characterized in the 1960s, arriving in blood gas analyzers as standard equipment by the 1970s and 80s. Blood gas analyzers specifically lean on ISE technology for reasons that go beyond convenience. Results in under 2 minutes on whole, undiluted blood, no sample prep or dilution step to introduce error or delay, and functioning reliably on the small sample volumes typical of critical care and neonatal specimens where every microliter of blood matters. The basic measurement circuit, conceptually, the sample contacts the ion-selective membrane. Ions in the sample interact with the membrane surface, generating a potential difference across it. That potential is measured against a stable reference electrode. The instrument converts the measured potential into a reported concentration using the electrode's characterized response curve. A standard blood gas analyzer's electrolyte panel typically runs 4 dedicated ion-selective electrodes side by side, each with its own membrane chemistry entirely specific to its target ion. Sodium, potassium, chloride, and ionized calcium, plus, in most modern panels, a pH glass electrode running the same underlying potentiometric principle. The membranes themselves split into 3 genuinely distinct chemical families, and knowing which family you're troubleshooting matters. Glass membranes for pH and sometimes sodium, liquid ion exchanger membranes built around specific ionophore molecules for potassium and calcium, and solid-state crystalline membranes for chloride. None of this happens in isolation from the rest of your quality system, either. Everything covered elsewhere in this series, Sigma metrics, Westgard QC rules, calibration verification discipline, applies in full to ISE electrodes exactly as it does to any other analyzer technology. The membrane changes the measurement mechanism. The quality framework on top of it doesn't change. Direct ISE blood gas analyzers specifically concentrate in exactly the settings where speed and small sample volume matter most clinically. Intensive care units, operating rooms, emergency departments, and neonatal units, where a delayed or large volume requiring electrolyte result can genuinely change the immediate management decision. A liquid ion exchanger membrane, the type behind potassium and calcium electrodes, is a genuine composite material. A PVC matrix, a plasticizer that keeps it soft and ion mobile, and the actual selectivity engine, an ionophore, a specific carrier molecule embedded within it that physically and chemically prefers to bind one particular ion over all others. Valinomycin, the classic potassium ionophore, illustrates the selectivity mechanism beautifully. A cyclic molecule with a central cavity sized almost perfectly to fit a potassium ion, coordinating it through oxygen atoms lining that cavity, sodium, being a smaller ion, simply doesn't fit the cavity geometry as well, giving the membrane genuine, physical selectivity rather than just a chemical preference. Each electrolyte's ionophore is a distinct molecule engineered for its target. Potassium relies on valinomycin or synthetic crown ether analogs. Ionized calcium relies on ETH 1001 or related ETH family carrier molecules. Sodium relies on ETH 227 or similar sodium-selective ionophores when a liquid exchanger design is used rather than glass. The chloride electrode works on entirely different membrane physics. A solid-state crystalline matrix, typically silver chloride or a silver sulfide silver chloride composite, where chloride ions participate directly in the crystal's own ion exchange equilibrium, rather than being selectively bound by a dissolved carrier molecule. The glass membrane used for pH and historically for sodium works through yet a third mechanism, hydrogen ions or sodium ions in a sodium-specific glass formulation, exchange with ions embedded in a thin hydrated gel layer that forms on the glass surface, generating the potential through that surface exchange rather than bulk membrane transport. Membrane selectivity in every one of these designs is never absolute, and that matters clinically. The Nikolsky-Eisenman selectivity coefficient quantifies exactly how much a membrane still responds to interfering ions. A potassium membrane retains some residual sensitivity to sodium, ammonium, and hydrogen ions, which is precisely why severe electrolyte derangements or extreme pH can introduce measurable interference into an otherwise well-functioning electrode. Practically, protecting membrane integrity comes down to habits familiar from any other reagent-adjacent component. Avoid mechanical contact with the membrane surface during any maintenance procedure. Follow the manufacturer's conditioning and storage protocol exactly when an electrode is new or has been replaced, and never allow a membrane to fully dry out between measurement cycles. Membrane thickness itself is an engineered trade-off, not an arbitrary manufacturing choice. Thinner membranes respond faster, reaching a stable reading more quickly, but wear out sooner under continuous specimen contact. Thicker membranes last longer in service but respond more sluggishly. Manufacturers tune this balance specifically for each analyzer's expected throughput and turnaround requirements. The membrane chemistry takeaway: 3 genuinely different physical mechanisms, ionophore carriers, crystalline exchange, and hydrated glass gel layers, all converge on the same electrochemical outcome, a measurable potential proportional to ion activity, which is exactly what the next chapter's math actually describes. If this level of technical depth on the electrochemistry is useful, subscribing keeps this series coming. The Nernst equation governs everything an ISE does, and it's worth knowing exactly, not just by name. The measured potential equals a constant term plus a term scaled by temperature and the ion's charge, multiplied by the logarithm of the ion's activity ratio across the membrane. Critically, the relationship between potential and concentration is logarithmic, not linear. That logarithmic relationship has a direct, practical consequence worth internalizing. At physiologic sodium concentrations, roughly 140 millimoles per liter, a genuine 10% change in true concentration only shifts the measured potential by a few millivolts, which is exactly why ISE electronics demand real precision in the millivolt range to resolve clinically meaningful electrolyte changes at all. No single ISE membrane potential means anything in isolation. It's always measured as a voltage difference against a stable reference electrode, typically a silver or silver chloride design held at a fixed, known potential regardless of sample composition. The complete electrochemical cell is the ISE membrane, the sample, a salt bridge or junction, and the reference electrode, all in series. The theoretical Nernstian slope, how many millivolts the potential should shift per tenfold change in ion activity, is a fixed number derivable directly from the equation itself. Approximately 59 millivolts per decade for a singly charged ion like sodium or potassium at body temperature, and roughly half that, about 30 millivolts, for a doubly charged ion like calcium. This theoretical slope is exactly what your instrument checks during every calibration, and it's the single most direct window into membrane health available to you. A slope measurably below theoretical, even while the electrode still technically produces a reading, is often the earliest, most sensitive signal of membrane degradation, well before the electrode fails outright. The electrochemistry level principle worth carrying. Every ISE reading is fundamentally a logarithmic voltage comparison against a fixed reference, governed by a precisely calculable theoretical slope, and how closely your electrode's actual slope tracks that theoretical number is the single best real-time indicator of its health. This is arguably the single most clinically important distinction in this entire topic, and it's frequently taught poorly. Blood gas analyzers use direct ISE, measuring undiluted whole blood or plasma directly. Most core laboratory chemistry analyzers use indirect ISE, measuring a diluted sample instead, and that difference is not a minor technical footnote. The reason this matters: direct ISE measures ion activity specifically within the water phase of plasma, which is what's physiologically relevant. Indirect ISE, because dilution assumes plasma is essentially all water, introduces error whenever that assumption breaks down. Most classically, when a large fraction of plasma volume is displaced by abnormally high protein or lipid content. Severe hyperlipidemia or hyperproteinemia is the classic teaching example, historically producing spuriously low sodium on indirect ISE, so-called pseudohyponatremia, while the same patient's direct ISE result, run on a blood gas analyzer, remains accurate because direct measurement never made the water fraction assumption in the first place. The practical clinical takeaway that should travel with every result: when a sodium value seems physiologically implausible, especially in a patient with known severe hyperlipidemia or a paraprotein-secreting malignancy, checking whether that result came from direct or indirect ISE, and repeating it on the other method if needed, is a genuinely useful diagnostic reflex, not an obscure technicality. Quick pause. If this breakdown is helping you, take a second to hit like and subscribe. It genuinely takes a lot of effort to make videos like this, and your support keeps them coming. Modern high-throughput lipid and protein handling has genuinely narrowed this discrepancy compared to decades past, but it hasn't eliminated it. Pre-analytical ultracentrifugation and improved dilution ratios reduce the error's magnitude without changing the fundamental physics that direct measurement simply doesn't share this failure mode at all. Calcium carries its own additional layer of the same principle worth naming. Direct ISE on a blood gas analyzer measures ionized calcium specifically, the physiologically active fraction, while many core lab panels report only total calcium, which includes protein-bound and complex calcium that isn't physiologically active at all. In critically ill or hypoalbuminemic patients, these two numbers can tell genuinely different clinical stories. The magnitude of the discrepancy scales directly with how far protein or lipid content deviates from normal mild elevations produce a negligible, clinically irrelevant gap, while severe derangements, the kind seen in decompensated multiple myeloma or profound hypertriglyceridemia, can produce a 10 to 15 millimole per liter gap between methods on the same specimen. Practical lab-side habits that catch this before it reaches a clinician. Flag results where sample lipemia or gross paraproteinemia is visually or analytically evident. Maintain a documented protocol for reflexively confirming implausible electrolyte values on direct ISE when available, and educate ordering clinicians on which method your lab's routine chemistry panel actually uses. Almost to the practical core, if this is useful for your bench work, helps this reach more working lab professionals. ISE calibration, as covered in passing in the broader multi-point calibration discussion, is deliberately different from photometric chemistry. Because the Nernst equation's logarithmic relationship is already known and fixed, ISE electrodes typically calibrate with just 2 points, a low and a high standard, rather than requiring a multi-point curve at all. The 2 calibration points let the instrument compute the electrode's actual slope directly. The measured potential difference between the 2 standards, divided by the known difference in their log activity, compared immediately against the theoretical Nernstian value from earlier to judge whether the electrode is performing as expected. Most modern blood gas analyzers automate this entirely, recalibrating far more frequently than a wet chemistry photometric method typically would. Often every hour or two of continuous use, plus after every sample batch on some platforms, precisely because the electrodes sit in continuous contact with patient specimens and drift is expected as a normal, managed part of operation. A slope that's degraded but still technically within acceptance limits deserves the same trending discipline covered for calibration curves earlier in this series. Plotted across successive calibration cycles, a steadily declining slope, even one that never fails a single individual acceptance check, is an unambiguous, trackable signal of progressive membrane wear. When a slope check does fail outright, the troubleshooting sequence is specific to ISE technology, not generic. First, confirm the calibration standards themselves haven't degraded or been contaminated. Then inspect the membrane surface for visible fouling or damage, and only escalate to full electrode replacement once both of those have been ruled out. The calibration level principle worth carrying. ISE slope is the electrochemical equivalent of the sigma metric covered earlier in this series. A single, trackable number synthesizing membrane health into something you can trend, act on, and defend in an audit. Membrane degradation over an electrode's working life follows recognizable patterns worth knowing by name. Protein fouling, where plasma proteins adsorb onto the membrane surface and physically block ion access. Lipid coating, a related but distinct mechanism more specific to lipemic specimens. Ionophore leaching, where the carrier molecule itself slowly migrates out of the membrane matrix over months of use, gradually eroding sensitivity. Fibrin and clot material in a poorly collected or improperly mixed specimen is a distinct, acute interference source rather than a chronic degradation one, physically obstructing the sample path or coating the membrane surface transiently, producing an erratic or failed reading on that specific sample without indicating any underlying membrane health problem at all. Distinguishing the two in practice comes down to reproducibility. Repeat a suspect result on a fresh specimen aliquot, ideally drawn or handled slightly differently. If the anomaly resolves, the specimen was the problem. If it reproduces consistently across multiple, cleanly handled specimens, the membrane itself is degrading and needs formal investigation. A full technical scenario, not a patient one. A potassium electrode's Nernstian slope drifts from a healthy 59 millivolts per decade down to 51 over 3 weeks, with calibration standards confirmed fresh and correctly prepared, and no single calibration event triggering an outright rejection along the way. The slow drift signature this series has flagged repeatedly as the hardest failure mode to catch reactively. Visual inspection under magnification confirms a thin, uniform protein film across the entire membrane surface, consistent with cumulative fouling from routine specimen contact over the electrode service life rather than any single event. Scheduled replacement per the manufacturer's expected service life interval, rather than waiting for outright failure, restored the slope to 58 millivolts per decade immediately. The troubleshooting discipline worth internalizing. A healthy ISE program replaces electrodes on a scheduled, trend-informed basis before outright failure, rather than reactively after a rejected calibration. By the time a slope check formally fails, degradation has typically been progressing trackable for weeks. Temperature appears explicitly in the Nernst equation from earlier for a real physical reason, not just as a formality. The potential a membrane generates at a given ion activity genuinely shifts with temperature, which is why every ISE-equipped analyzer thermostatically controls the measurement chamber precisely, typically at 37 degrees Celsius, rather than compensating mathematically after the fact. Daily QC on ISE systems follows the same Westgard and Sigma discipline as every other analyte covered in this series, with one electrolyte-specific nuance worth flagging. Because ISE electrodes recalibrate so frequently, QC materials should be run close enough to each recalibration cycle to genuinely capture the electrode's real-time performance, not just its performance at the last scheduled check. Preventive maintenance specific to ISE systems spans a genuinely practical range. Scheduled membrane replacement per manufacturer interval rather than reactive replacement, reference electrode filling solution changes on their own separate schedule, and periodic verification of the sample path and junction integrity that connects membrane, sample, and reference electrode into one working circuit. Weighed honestly against alternative electrolyte measurement approaches, ISE Technologies' case rests on speed and sample compatibility more than raw precision. It wins decisively on turnaround time and small sample compatibility for critical care, while flame photometry, largely retired now, and colorimetric wet chemistry methods can offer marginally different precision profiles depending on the specific analyte and clinical context. Every ISE-related nonconformance belongs in the same documentation discipline covered throughout this series. The specific membrane or electrode implicated, the slope trend leading up to the event, the corrective action taken, replacement, standard remake or junction service, and the verification confirming resolution, time-stamped for the accreditation file exactly like any other corrective action. Pulled together, a genuinely complete ISE health assessment looks at slope trend, calibration frequency and stability, QC performance against Westgard rules, and documented maintenance history simultaneously. The same multi-dimensional synthesis this series has applied to photometric calibration, now applied to the electrochemistry underneath your electrolyte panel. One misconception worth retiring before we close. An ISE electrode that's still producing readable results does not mean it's still performing at full sensitivity. Slope, not just the presence of a number on screen, is what actually confirms a membrane is working correctly, and trending that slope is the only way to catch degradation before it becomes a rejected result. Ion-selective membrane technology turns an abstract electrochemical principle into some of the fastest, most clinically trusted results in the entire laboratory. Understanding the membrane chemistry, the Nernst equation behind it, and the direct versus indirect distinction changes how you read, trust, and troubleshoot every electrolyte value that crosses your bench. Final recap. Ion-selective membranes generate a voltage proportional to ion activity, following the logarithmic Nernst equation. Potassium and calcium use ionophore-based liquid membranes. Chloride uses a solid-state crystalline membrane. pH uses hydrated glass. Direct ISE, used in blood gas analyzers, avoids the dilution assumption that can distort indirect ISE results in severe hyperlipidemia or hyperproteinemia. And electrode slope, trended over time, is the earliest and most reliable signal of membrane degradation. Here are the key references and sources for this video. Thanks so much for watching. If this helped, like the video and subscribe for more clear, simple explainers, and I'll see you in the next one.